The quality of the conference, what is going on right now, and the scientific content is amazing. And I think whoever is sitting there, and I should also compliment the speakers before me, that the scientific content has been excellent. So I think we should keep up the momentum and take it further. So we are at this particular stage in the conference where now we're slowly moving on to assessments. Like I said yesterday, there are multiple ways to skin a cat. What I'm going to talk to you about is one other way of assessment. So I'm going to talk about drug-induced sleep endoscopy, which for a lot of you is not a new thing. Now, it started way back in the early 90s in the UK, where Pringle and Croft came up with this beautiful idea. Since you can't go into people's house and put scopes into people's houses and bedrooms and put scopes through their noses and see what's going on, is there some way with a wire media in between where we can actually mimic sleep in an artificial environment and try and see what is going on, because we are trying to assess and validate and treat obstructive sleep apnea. So why is this very important? Now, as you all see here, we all know that overnight polysomnography, whichever level it might be, is a gold standard in diagnosing sleep apnea. However, it fails to identify as to which patients are likely to succeed with alternatives of sleep apnea. I'm not only talking about surgery. I'm also talking about other means. I'm talking about mandibular appliances. I'm talking about, strips. I'm talking about other means. So multiple evaluation techniques have developed to examine the individual pattern. Remember the word pattern of airway obstruction, each with its own strengths and weaknesses. We've just seen Vijay come up with beautiful MRI pictures, dynamic cine MRIs. So currently, again, there is no gold standard method to determine the level of airway collapse. However, the most commonly done for most of us is the Muller's maneuver in an awake supine patient. There are others. There are plain cephalograms, cephalometries, there's CT scans, there is CineMR. So one such method is drug-induced sleep endoscopy. Now, what are the key features of this kind of assessment? So what you're basically doing is you're using different pharmacological agents to achieve sedation. The goal is to reproduce the upper airway behavior, which is similar to the one in sleep which is happening to the patient. So what are the indications? Who are the patients that you would like to take up? It's indicated when you want to do surgery. It's indicated when you want to put a patient through some kind of an appliance. There are no absolute contraindications. Well, there are certain limited relative contraindications. The AHI being if they are more than 70. I was just baffled to see that sleep report of the person who's like 100. I've never seen such a big AHI in a patient. So, well, this can be a relative contraindication. There are no absolute contraindications because remember, you're doing it in a very controlled environment. So what are the prerequisites? Yes, patient should have a basic cardiorespiratory monitoring, must be possible to administer oxygen if needed, and these two things is the best way that you can mimic sleep, a target-controlled infusion system for propofol or midazolam, but unfortunately we still don't have it in India. A bispectral index scoring system, which we now have and which me and Vikas have implemented doing with bispectral index scoring, definitely validates whatever you're doing, bringing you closer to a real sleep situation. So the patient shows up in NPO, you give something like glycopyrrolate half an hour before the surgery, a topical anesthetic not to overflow too much into the pharynx. This is important. So you can use your 10% lidocaine spray, but it shouldn't be too much to kind of go trickle down into your throat and cause numbness in the throat pharyngeal receptors. So view with a flexible scope on the screen, and Important to help with the microscope so that you're actually recording acoustic signals, the snoring and the visual signals should be recorded simultaneously. Very shortly about the drugs. This is the pharmacokinetics and pharmacodynamics. Well, they're all there in the textbooks. So what you're doing here is, if you're taking propofol as the drug of your choice, it should be 1.5 milligrams per kg, or could be a continuous infusion. I would suggest that please don't do it by yourself. Yes, we can play around with midazolam and propofol by ourselves, nothing will happen, but always keep an anesthetist, because remember, we're dealing with a syndromic patient here. And since we don't have target controlled infusions, we use as boluses. So this is the DISE equipment to validate your data. This is how the strip is put in, which is actually a use and throw. Us being Indians, we use it 3 times. Can I have the video, please? Play the video. This is the procedure being done. Can you hear the, I need an audio. So this is in our setup with the BIS there. Remember, it should be having an apneic episode there. He's actually breathing, but you can't hear. Now it let go and the air is going in. Look at this here. It's about 82, 84. Am I scared of it? No, because if you do a polysomnography, you know his LSATs are about so much. So you don't have to be scared doing the procedure. Now, once you've done your beautiful DISE, so what do? Unfortunately, there is no universal scoring system for this kind of examination. So recently, a group of doctors from the US and Netherlands put up a scoring system called the vote score classification. Let me basically run you through this. Why do we need a classification? Because if I do it here and somebody else is doing it in Delhi and somebody else is doing it, so what, we don't speak a common language, like how we speak English in India as a common language. We need a common language to validate our data so that we can put all our data together and kind of go into an international form and publish it. So what do the structures what are the structures of the acronym? Now, velum, as you've seen from the big velum, O stands for oropharynx, tongue base, and epiglottis. So each one of them you're supposed to see and examine. Now, velum, it can collapse in an AP way, it can collapse laterally, it can collapse concentrically, and based on that, you give particular marks to it, like how we do in pediatric airway. So 0, 1, 2, and not visualized. So this is a patient, not propofol is not given yet, just midazolam is given. Look at the movement. He's in apnea. Now little air is going there. There you go, again apnea. He's trying to breathe, but he's not able to. Okay, so what is going on with this guy inside, if you actually see? This is the common salpingopharyngeal folds. This is the velum. So look at the kind of collapse that's happening here. what is more interesting than this is the next DISE. Okay, you see a circumferential kind of collapse that is happening here. And beyond this point, one we go, just pay attention to the video there. Of course, this is a lateral type of collapse that is happening. Pay attention there. Look at that. How will this guy benefit from a CPAP? He's just not able to breathe there. So it's a retroflexed epiglottis. And this guy came back on the first day he was put on a CPAP saying that I have a choking sensation, I feel I'm going to die. So that's what he came out with. So, we should have some, how can you tell this guy that, well, that's it, you can't use a CPAP, well, I have nothing else to do for you. I will either trach you or that's it. And I have an interesting slide here. A slide wherein for the same patient, I have compared modified Muller's and what I have found is as long as you're in the upper level, retropalatal level or upper velum level, things are fine. But if you want to diagnose, here you're not able to see the epiglottis, what is happening to the epiglottis. This is the same patient's epiglottis. Okay, and see how it's getting compressed by the lateral walls. That is something I don't think a modified Muller's in an awake patient will be able to pick up. Yes, there's a lot of study that needs to be done. We're putting up a study together wherein we're actually comparing our Muller's of the same patients with drug-induced sleep endoscopy. We have 15 patients so far. So let me just talk about the advantages. So it's basically a dynamic assessment of sleep. You're directly visualizing the site of obstruction, the structures causing it, and also the pattern of obstruction. It's a good test, and there is reliability in it. Because if there is retest reliability in it, that means if I'm doing it and some X, Y, and Z are also doing it, we're all saying that, okay, this is what it is. And another important thing is you can do the S-mark during the same procedure. If you want to give the patient a mandibular repositioning device, you can do the S-mark during the procedure and actually see the advancement of the airway and also see that the lateral walls also become taut and not collapsing. And another interesting thing is the one that we saw in Rome, actually, this guy in Germany who's actually put the PAP and along with it put the endoscope and see how the positive airway pressure is blowing the airway open. So if you can actually see that, you'll also know that why probably a CPAP is not working for him or why the CPAP is working for him. Yes, it is time consuming. Yes, it is costly. And more importantly, over sedation can reduce muscle tone more than you want to actually. That's also very important. So if you have target controlled infusion, you have BIS, you can actually, kind of iron out these things. And it can also reduce respiratory drive because after all, propofol is an agent that is used to induce anesthesia. So if you are actually reducing the respiratory drive, you're actually stimulating central apnea, and that's not what our aim is. Complications, yes, oxygen desaturation is a possibility, so you should have the facility to kind of give oxygen. Saliva aspiration can occur, there could be laryngospasm, and DISE may be performed concurrent with positive airway pressure assessment. This is something that is, How do you prevent complications? Now, to prevent complications in high-risk patients, such as ones with huge body mass indexes, about 35, etc., it is problematic in especially patients with short necks. You should be very careful. And Mallampati position 4, how do you prevent complications in these people? Well, one is When you select them, you tell the patient, take a proper consent, tell them that this is a diagnostic thing, is not it's not a solution for your problem. You have certain anatomical abnormalities per se, your problem is a syndromic condition. Explain to the patients, you be careful, always keep an anesthetist. You can definitely come to a conclusion with DISE. So, thank you very much.
Thank you, Kishore. You are absolutely on time. But please wait, there are going to be some questions for you, I am sure.